Everybody, my name is Ernest Braxton. I'm a board certified neurosurgeon working here in Vail, Colorado with Vail-Summit Orthopedics and Neurosurgery. And thanks for taking some time out of your day. I know there can be a lot of Zoom fatigue with all these lectures and things like that, but I thought I would just give you an overview of some of the new updates in minimally invasive spine surgery that we're doing, um, accomplishing our surgical goals with less pain and faster recovery. Um, I really like this phrase. It's "Wegen aber besser," and it's just German for less but better. And I really believe that minimally invasive spine surgery is not a procedure; it's a philosophy. I want to talk a little bit about some of the ground rules. There should be some time for questions. We have a a hard stop in 25-30 minutes or so. We'd ask you to stay muted during your presentation. You can use the chat option, um, and when you use that feature, the moderator will ask your question, and and if it's a question that doesn't have private medical information, I think that we'll answer it right during the talk. So feel free to interrupt me with questions, but use the chat option. So this is what we're going to talk about today. We're going to talk about spinal cord stimulation to treat chronic back and leg pain, outpatient awake surgeries, it's a new technique that I've been developing here in Vail, Colorado, motion preservation surgery, which involves not fusing the spine, but trying to preserve the motion, usually with an artificial disc. And then I'll give you a little bit of information if you have any patients that you want to refer over to us. So let's talk before we can really understand who needs a spinal cord stimulator and who are candidates. We have to understand there are different types of chronic pain. Definition of chronic pain is pain that lasts greater than 6 months. Some folks say greater than 3 months, but pain that's lasting greater than 6 months is abnormal and can be treated. There's mechanical or neuropathic pain. The spinal cord stimulators are for neuropathic pain, nerve pain, symptoms that occur with or without a trigger, symptoms that may involve weakness, numbness, pins and needles feeling. We sometimes call that dysesthesias, shooting, burning, or stabbing pain. These are all can be treated with a stimulator. Um, if the chronic pain is preventing your patients from enjoying routine daily activities around the house, ability to work and be productive, playing with children or grandchildren, being outdoor activities, gardening activities, crafts, just making you miserable, then we start to put you in the realm of somebody that might need treatment. Uh, Many of the patients have tried other things like narcotics, physical therapy, drug pumps, spine fusion operations, failed surgeries, nerve blocks, and non-steroidal anti-inflammatory medications. But when you fail these other treatment strategies and your pain has gone on for greater than 6 months, I think it's time to refer and consider a spinal cord stimulator. Uh, a spinal cord stimulator is a medical device that is designed to block the patient's perception of pain. It doesn't alter the geometry or anatomy of the patient, but it does alter the physiology of the patient. By placing an electrode on the spinal cord, we can, by a number of different mechanisms, block the patient's perception of pain for profound and fast pain relief. Common diagnosis for people that need a spinal cord stimulator might be failed back syndrome. That's probably my most common diagnosis. I see a patient who's had one surgery or multiple surgeries, and they're still suffering with chronic pain. Patients that have neuropathy, sometimes called CPRS, complex regional pain syndrome, are great candidates for spinal cord stimulators. Patients that are on average have pain that's greater than 5, or patients that have failed physical therapy, a TENS unit, epidural injections, radiofrequency ablations, and still have pain, then we think that a spinal cord stimulation is a good option to consider. Spinal cord stimulator, a lot of my patients have heard about it. Even a lot of my referring physicians and physical therapists have not heard about spinal cord stimulator, but it's been in practice for over 40 years. And did you know that the first use of neuromodulation or electricity for pain was actually in ancient Egypt? They used an electrical eelfish to treat arthritis. So it's been around since antiquity, since and continues to be a part of medical practice. It's a non-drug therapy, but there is a dose, and the dosage comes in the form of electricity in a waveform. Uh, they may result in decreased dependence on oral drugs, including narcotics, um, generally covered by most insurance plans. And the frequencies and the waveforms being used are constantly being evolved and constantly improving. And with any surgery, we cannot guarantee an outcome, um, but uh, and there are a risk of complications. But this is an outpatient procedure, and patients tend to do very well in terms of complication side effects. So a spinal cord stimulator generally works through two main pathways. If we think of our anatomy of the spinal cord, there are cells called in the dorsal column, and patients can experience pain relief through tonic stimulation or through blocking the sensation by replacing it with another sensation that's more pleasant. And they also work by inhibiting intermotor neurons in the dorsal horn. That's subperception therapy. There are newer therapies that involve a combination of both of these techniques, and we often combine different waveforms to address a patient's pain. Uh, every person that gets a spinal cord stimulator should have a trial before it's implanted, and it's one of the few surgeries that I do that's totally reversible. It's a try before you buy situation. So if I think it's indicated, since pain is such a personal experience, I put it in a trial set of electrodes for about 7 to 14 days. And if the patient has greater than 50% pain reduction, improved functionality, decreased medication usage, and better sleep, more productive sleep, then we can indicate them for a permanent implant. Spinal cord stimulators provide targeted therapy that can have paresthesias, or I call them champagne bubbles, this kind of sensation around a painful area. Like if you have a painful area, you don't have to go to medical school to know that it helps when you rub that painful area. Or it can be paresthesia free or combined. Many of my patients who have a successful spinal cord stimulator will have different programs for different activities. They may have a program for sleep, for work, and for play. It's very personalized, profound pain relief um, in the appropriately selected patient. Uh, this is a study that shows just on the NRS, the numeric pain score. You know, asking a patient between 1 and 10, what is your pain, and what is your pain relief up to 2 years. We see a profound reduction in pain, going from 8.6 to 2.8. Occasionally, we hit home runs and when they have complete pain relief, but more commonly, they have greater than 50% relief of their pain, enough to carry on with their daily activities. Um, like I said, this technology has been studied and is approved by the FDA and is considered safe and effective for chronic severe back pain and leg pain. We have a lot to cover today, and if there are more questions about spinal cord stimulator, I can go back over them. But I do want to cover the rest of the topic, and the next topic is going to be awake minimally invasive surgery. Traditionally, surgery has been done under a general anesthetic with sometimes a prolonged recovery, keeping the patients generally at least overnight in the hospital. Although you can go home the same day with a general anesthetic, but we're developing techniques to remove arthritic bone or stenosis in the spine without putting the patient to sleep. This has several distinct advantages. One, avoids the risk of a general anesthetic. Two, it allows for communication with the patient and the ability to examine the patient while they're in the operating room, to know that the surgery is safe and it's not hurting them, and also to know that the surgery is effective at relieving why they're in the operating room in the first place. And it's not uncommon that I'll do an operation for either a disc herniation or stenosis, and patients will start to feel relief while on the operating room table, and that's a great feeling. The last reason for doing an awake, I believe, is more about making it a patient-centered operating room environment. Um, there's uh, there's more humanism, I believe, for the patient, more respect for the patient. The patient knows that I'm not doing other surgeries concurrently with their operation. They know that I'm there. And it even comes down to the music that we listen to while we're in surgery. The patient picks the music, I don't pick the music. Uh, Spinal stenosis is generally worse with walking and standing and relieves with bending over or sitting. And one of the key questions I ask all my patients who I suspect have stenosis is if leaning over a shopping cart improves their pain. Uh, what happens is there's crowding around the nerves from ligamentum flavum hypertrophy. That's a ligament within the spine. It causes stenosis, and it starts causing claudication type symptoms that gets worse with more and more activity. Oftentimes, the patient with stenosis will get better if they sit down and lean over. Traditionally, we would have to make an incision on the patient's spine, remove a large part of their bone called the lamina, and do this under a general anesthetic. But with improved technology and improved anesthetics, we're able to do this awake. And here is a surgery where you can see that the nerves are crowded from overgrown facet joints, the joints in the back of the spine. And through this procedure, I'm able to open that space up and to give the rooms just enough space to relieve the patient's symptoms. It can be formed awake, generally a small incision measuring about 2.5 centimeters. Most patients go home the same day. I'd say the vast majority go home the same day. The nerves are decompressed with a microscope, and it leads to a speedy recovery, with most patients feeling back, recovering in about 2 to 4 weeks after surgery. Going on to the next topic, which is motion preservation. Motion preservation is done anteriorly from the front of the spine. These surgeries are done with a general anesthetic, and we can replace discs in the neck, artificial discs in the neck and in the back. And I also want to talk a little bit about how we safely access the spine and how we mitigate the risk of doing an anterior approach. Um, Artificial discs are indicated in patients who have neck and arm pain that lasts greater than 6 weeks, and as an alternative to fusion. All patients who are candidate for an artificial disc surgery are also candidate for a fusion as well, but we believe that preserving the motion decreases the risk of something called adjacent segment disease. Adjacent segment disease results in breakdown a level 1 or 2 above the patient's spine. The spine tends to degenerate in a stepwise fashion, first by thinning or sometimes tearing the annulus around the disc, then with a disc bulge, or sometimes with a frank disc herniation. This often can result in arm pain. By removing the lesion or the pathology that's compressing the nerve and replacing the disc, we can preserve motion and as an alternative to fusion. I wanted to show a quick video that kind of demonstrates the motion preservation differences between an artificial disc and a fusion. There's still motion in a fusion, but it does put more stress above and below the fusion site, kind of highlighted in red. And by putting more and more stress, we believe that segments above and below the fusion will tend to wear out faster, leading to possibly another operation. This is the 10-year data was recently published. This has the 7-year data. The 10-year data reflects the 7-year data in that artificial discs significantly decrease the rate of adjacent segment disease compared to fusion patients. The rate of major complications was less than doing a fusion operation, and the return to work was 20 days sooner for artificial disc when compared to fusion. Similarly, artificial disc can also be placed in the lumbar spine. These are an alternative to fusion for patients who have severe degenerative changes, intractable back pain lasting usually greater than a year. In the lumbar spine, we're currently only doing them for single level, although there's been recent approval for multi-level artificial disc surgeries in the lumbar spine. And then what we see is a similar process in the cervical spine where the disc thins out, bone spurs develop, and there's abnormal motion in the spine. The artificial disc allows folks to regain their motion, decompress nerves, and improve their pain. Most patients still have some pain after an artificial disc, but usually it's greater than a 50% reduction in their pain prior to surgery. Patients are generally able to return to work with unrestricted activities and discontinue narcotics, and that's what the data is showing us. Similarly, adjacent segment disease is less. I'm going to go through this slide quickly. And then I just wanted to highlight this to show the profound relief in pain um, um, prior to surgery. And this is the durable effect lasting out to 7 years. And this 7-year data is recently been published in the International Spine Journal. Talking about postoperative care pathways, this is a paper I wrote in 2019 showing early return to work and decreased uses of narcotics. And it depends on your job. For a sedentary job, most of our patients can return in 1 to 2 weeks. For more physical work, 6 weeks, and work involved heavy lifting in 6 to 12 weeks. The 7-year paper was recently published, but this is the 5-year paper. I'm an author on the 7-year paper, but it shows decreased narcotic usage, improved function, and decreased disability, with 86% of patients returning to full work. Lastly, I just want to address some concerns about anterior spine access. This is a multidisciplinary approach. I always use a spine access surgeon that has specialized care and experience with it when approaching the spine. Candidates for anterior spine surgery should not have advanced vascular disease, limited previous abdominal surgery, and generally what we consider good health. There's a quick video that I want to show that kind of demonstrates kind of the process of approaching the spine. It's a retroperitoneal approach that's done on the patient's abdomen. About a 3-inch incision is made after the skin is cleaned and sterilized, prepped, and draped. This is a longer video. I'm going to speed through this a little bit and kind of describe it, but the peritoneum, which contains most of the organs, the bowel, is all mobilized retroperitoneally. The veins are protected with retractors, and the spine is safely approached. And this is done by my spine access surgeon. Once the spine access is accomplished, that's when we go and remove the diseased and damaged disc and replace it with a new one, a prosthetic device. Most patients stay in the hospital for 1 to 2 days and need about 6 to 8 weeks of physical therapy, which consists mostly of nerve glides and core strengthening. Now, I want to talk a little bit about the risks. There are some risks. They're small, but not zero. There's a risk of an injury due to moving one of the blood vessels of less than 1%, injury to the bowel or other abdominal organs of less than 1%. In males only, retrograde ejaculation has been reported as a statistic less than 1%, which is temporary in only half of the patients. I wanted to make sure that we had some time for questions regarding spinal cord stimulators, regarding awake minimally invasive decompression surgeries, and also artificial discs, both in the cervical and lumbar spine. So with that, I just want to take a little bit of time to see if there's any questions out there before we conclude our presentation.
Dr. Braxton, this is Leslie, and I've been looking at the chat, and there was just one question about limitations from a physical therapy stance on spinal cord stimulators, if there's any precautions. I did kind of answer that question, but and I answered it by saying that the limitations are for the first 8 weeks, and once they are past the healing process, that we generally allow them to return to any regular activity. But I wondered if you wanted to expand on that at all.
So the biggest risk of a lot of excessive physical activity with a spinal cord stimulator is lead migration. The lead is placed um, over the dermatomal map of where most of the patients have. And with a lot of bending, lifting, flexing, or twisting, these leads can migrate. They tend to move less or migrate less after about eight weeks, because then there's epidural fibrosis that secures the lead in place. Now, occasionally, once or twice a year, we'll have a patient who's doing a very aggressive activity, say a bad ski fall or a car accident, and their leads will migrate. The leads migrate. Sometimes we can still capture their pain area with another part of the stimulator, but oftentimes we have to replace and revise the lead. So after about 8 weeks, they're unrestricted activity. We usually get people in physical therapy sooner, but it's more for um, functional measurements of how they're doing after surgery. And I don't really want to stress them during the therapy appointments, but I just want to see how far they can bend, how far can they lift, can they return to work with a spinal cord stimulator. That was a great question, Leslie. Any more questions?
Are you there? Sorry.
I'm there.
The other question was, are they limited for, skiing, snowboarding, mountain biking, all of those things with a spinal cord stimulator and once they're healed?
The answer is no. After 8 weeks, they can do whatever they could do before surgery. If they could play the piano before surgery, they can play it afterwards. But we just got to give sufficient time for it to heal and for the lead to be secured in with a little bit of epidural fibrosis, which occurs naturally around the lead to anchor it.
And then there's one other question. It was, have you ever seen any lumbar disc replacement failures which required revision or future fusion? Is there an expected timeline for how long they should potentially be lasting?
The answer is yes. It's a serious complication if the artificial disc fails. I think in my 12-year career, I've had 4 failures where I've had to revise them. And I generally revise them to a fusion, although there's some evidence that points that we can revise them to a newer artificial disc. The artificial disc failures have usually been because of either activity too soon after surgery or too much activity after surgery. And the one failure I'm thinking of in particular was a CrossFitter that was doing a lot of power cleans over and over, and the implant migrated, and it needed to be revised to a fusion. Since then, there's been an engineering change in that, and I have not seen it since that engineering change with the implant. The devices are generally said to last 60 to 70 years after implantation. And that's based off of in vitro testing and biomechanical testing. The implants have not been around for 60 years, but based off of wear debris studies, stress and deformations biomechanical studies, we believe they will last 60 to 70 years. So I've not replaced one for wearing out. I've replaced them for the implant itself failing. That was a good question. Any other questions?
Right now, I'm not seeing any further questions in the chat. Does anybody else have a question they'd like to ask?
Well, everybody's going to be getting an email after this short lecture about how to contact us to ask more questions or to refer a patient. I do have to jump onto another talk, but if there's no more questions, I'll conclude this this talk. And I appreciate everybody's attention and hopping on Zoom for the 100th time during COVID. Hopefully, the next time we do this, it could be at a nice dinner or conference. But we'll see. We're trying to obey all the guidelines and do this in the safest way possible. Okay, folks, I'm gonna sign off here. Thanks everybody for their attention. And again, you'll all be getting an email how to ask more questions and how to refer a patient. Thanks so much.